Right, welcome everybody. Welcome from Lumley Castle, and for those attending virtually, I'm Ali Khan Bandali. I'm one of the consultant cardiologists at Sunderland and South Tyneside District General Hospitals. So it's my pleasure to chair this meeting. I don't know if we can go to slide 2 on the clicker. There you go. I'm chairing. So for full disclosure, I've received speaker fees from Alnylam and AstraZeneca. So this meeting is about amyloid, which I guess is why you're all here, and setting up an amyloid MDT. So I'm very grateful to Alnylam for providing the funding for this meeting, and also to Paul Reynolds for helping to organise this and set it up. So I'm also very pleased to invite healthcare colleagues from multiple centres nationally. But I would stress that this meeting is for healthcare professionals only. And as such, we will be following the UK ABPI Code of Practice. So as part of that full registration, I'd be very grateful if the participants virtually could, in the chat, put their name, institution and specialty, just so then we know who's attended and to sort of get things going. So, next slide. Sorry, can we go back? Thanks. This meeting is being recorded, so please adjust your video and your audio settings to whatever you're comfortable with. It is always nice to see people in person, but also virtually, so feel free also to leave your video on. That's especially true for the question and answer session at the end. So the objectives of this meeting are threefold. We would like to look at the utility and the logistics of a regional amyloid MDT to allow earlier diagnosis in the pathways for AL and ATTR, and also for optimizing patient care in a multidisciplinary setting. So a quick look at the agenda. I'd highlight at the end the question and answer session. So if you have any questions at any point, please feel free to put them up as and when they come up in the chat, and we will endeavour to try and answer them in the chat unless a theme becomes clear. And what we'll do is we'll bring that to the question and answer session at the end. So I'm conscious that time is ticking, and I'll be holding these guys to time. So I'm first of all very grateful to the Leeds group for coming up to speak to us and to come all this way on the A1 for this meeting. Not all of them here yet. So to start off, as a change in the agenda, Dr. Alex Sims, who's a consultant cardiologist at Leeds Teaching Hospital, who has a specialist interest in heart failure and implantable cardiac electronic devices, is going to talk to us about ATTR amyloid and the patient pathway in that way. He's also a central member of the Inherited Cardiac Conditions Leeds group, which is certainly a service that we're sort of hoping to emulate in the Northeast. So, Dr. Sims, thank you very much for coming to speak to us. Take them on.
Can I grab the clicker? So, thank you. So thank you very much, and good evening. It's great to be here in Lumley Castle. It's a very nice setting. It's very odd to be face-to-face. I'm not used to this, so bear with me. I've done 2 years of virtual presentation. So my name is Alex. I'm a cardiologist in Leeds, and I was asked to talk to you today about ATTR amyloidosis, the red flags, and really the diagnostic pathway. So these are my disclosures. So very briefly, we're going to go through the red flags for ATTR, look at how we diagnose cardiac ATTR specifically, as that's something I can talk about. I can't talk much about the other aspects as well. And briefly touch on family screening and how we might want to address that. So you may know already that TTR is a protein excreted primarily by the liver. Some of that is also a little bits of secreted by the retina and the choroid plexus. And TTR has a function of carrying thyroxine and retinol binding protein. It comes as a tetramer, so 4 separate units. It's secreted into the blood, and when we have amyloidosis from this protein, we get dissociation of the protein. That's either related to mutations that weaken that binding of the 4 units, or alterations in the protein due to more degenerative changes due to cleaving or proteolytic effects on the protein. And once they dissociate, they start to misfold, and essentially they form these amyloid fibrils, which are essentially insoluble and get deposited in tissue. So, a typical amyloid story, but that is a TTR. And simply, it is either split into hereditary or wild type. Hereditary, as it sounds, is due to a mutation in the TTR gene, which is a fairly small gene, and we can map most of the mutations within that gene. It's an autosomal dominant inheritance, and has a sort of very variable penetrance and expression, which is maybe one of the problems with hereditary, and we'll come onto that when we talk a little bit about family screening. Wild-type ATTR, or less favorably mentioned senile ATTR, is that. It's an age-related issue. It's an age-related protein misfolding problem, probably due to the fact of the way the cell handles the protein as it's being made and cleaved. And that is probably the more common form. So what about the red flags? So I've split the red flags into cardiac and non-cardiac for my simple mind, really. So cardiac, when we come to looking at cardiac features of ATTR, the most common presentation, the one that always gets me suspicious, is heart failure. Now, we see lots of heart failure, so why does that get me suspicious? Well, it's heart failure syndrome. It often has preserved ejection fraction, so their echo looks to be functioning reasonably well. They may have a degree of LVH on their echo, but they often have very disproportionate symptoms. They have a lot of right heart failure. They have a lot of fluid overload. So heart failure is a very common presentation. They may have conduction abnormalities. Atrial fibrillation is quite common. You've got quite a restrictive cardiomyopathy picture here. You get atrial dilatation. You also get infiltration of the atria, which leads to areas of scar and likely exacerbation of arrhythmia. You may get problems with bundle branches, so about 20% of amyloid patients may have a bundle branch block, and they also get AV node conduction issues, and it's not uncommon to see patients coming to our clinics with pacemakers before they've actually reached the diagnosis of amyloid. A fair few get aortic stenosis, and valves you'll see on echo do get a bit thickened, and a proportion of aortic stenotic patients are found to have ATTR amyloidosis. And then you get more subtle features. So you may have a patient arriving with chest pain. Maybe the troponin is up, and that's another feature we do see with amyloid. But they've got normal coronary arteries. So again, just the suspicion in an older patient, normal coronary arteries with a slightly thickened ventricle, maybe with a bit of heart failure syndrome history, you want to be thinking possibly of cardiac amyloidosis. They tend to have an intolerance to typical heart failure medications. Beta blockers aren't well tolerated. When you've got a very stiff ventricle, you don't have the capacity to increase your stroke volume, so you rely on your heart rate. If you drop your heart rate off, you drop your cardiac output. So they feel rot and they get lower blood pressure. And sometimes you see patients who have previously been hypertensive treated, and they've then become more normotensive or hypotensive. Again, these are less clear but more subtle combination maybe with the other features we've mentioned. But heart failure syndrome is the one I've noticed most, and that's one you need to have your sort of high index of suspicion for. And this slide just highlights that wild-type ATTR is probably far more common than we realize. And when I came into role about 8 years ago, I'd hardly seen many amyloid patients from a heart perspective, but started looking, and they were everywhere. And I very distinctly remember my first light chain amyloid patient. But if we look at 85-year-olds who have undergone autopsy, about 25% of them have evidence of TTR involvement in the heart. Now, whether that actually transpires into a disease condition, I think, is debatable, but it is probably happening on a larger level in lots of patients and then in some peaking in towards disease. There's an interesting study a few years ago that 13% of patients over the age of 60 who were hospitalized with heart failure were found, they also had LVH, sorry, they were found to have ATTR amyloidosis on technecian DPD scanning, which is sort of the gold standard diagnostic test that we use. And about 10 to 12% of patients who were having a TAVI were also found on DPD scanning to have evidence of cardiac amyloidosis. So it is there if you look for it, and I think that's the key. The key is to have it in your mind when you're starting to see these people with features that are a bit unexplained. So heart failure, it's not quite fitting with the echo or other biomarkers that are significantly elevated. And when we look at the non-cardiac features, so typically they are older patients. They are typically male, and we don't really know why that is, but that might be because we don't recognize it in females, or maybe there is a biological reason for that. There's also a slightly higher incidence in certain groups of patients, so Black African Americans or West Africans tend to have a higher incidence of this V122I mutation. Now, it's quite a high prevalence of 4 to 5%, and not everyone with that mutation gets the phenotype of amyloid, but certainly we see a higher incidence of cardiac amyloidosis in that cohort of patients. And then there are other amyloid mutations that are endemic, such as the Sweden-Portugal cohort, but there's also an Irish and ancestry mutation, the T60A, which we tend to see a slightly higher incidence in these individuals. And this diagram just highlights really that this is not just a disease of the heart, it's a systemic disease. And the blue highlights the key features that we see with a TTR wild type in amyloidosis. So heart is universally affected in nearly 100% of cases. If you speak to a patient and ask them about carpal tunnel syndrome, and you've already confirmed that almost 100% of the time they come back to you and say they've had carpal tunnel surgery or they've had that. So carpal tunnel syndrome is very frequent, but it's also an extremely frequent thing in the population. So it's not very specific, but it will certainly be there if you hunt for it. And also lumbar stenosis or spinal stenosis is very common. You may get other features as well in later wild-type ATTR, which tend to present a bit earlier in the hereditary form. So the hereditary form tends to have a more of a peripheral neuropathy picture, tends to have a more of an autonomic dysfunction. Now, unfortunately, you can't see them on here. They were on there when I handed the slides in, they've disappeared. So what about ECG clues? So the one thing that everyone reads in the textbook is low QRS voltage. Now, that tends to be in the lateral leads, and you tend to get a disparity in the lateral leads to the precordial leads. The precordial leads tend to have a normal voltage or even an LVH pattern. Now, you don't get that in many other conditions, such as pericardial tamponade or effusions or obesity, where you get universally low QRS voltage. You may get other patterns like pseudoinfarct pattern tends to happen with more light chain patients because it's more toxic to the myocytes. And as I say, AF is very common. And you may get abnormalities of the P wave, again, due to the dilatation of the atria, but also the fact you get infiltration of amyloid in the atria, often lowering the conduction point of the atria. Echo can be quite suggestive. This echo is quite suggestive. First thing you note here is biatrial dilatation. That's due to the fact this is a restrictive pattern. You've got left ventricular hypertrophy. It's quite common to see right ventricular hypertrophy. You get intraatrial septal thickening. You even get valve thickening. Unfortunately, this is meant to play, and you don't see the valves moving on this, but certainly it would be evident if they're moving. You quite commonly see a pericardial effusion as well, not a big one, but it's a small trace of fluid. And then you get this description of speckled appearance. Now, speckled appearance can be very common. Certainly if you turn the gain up on your echo, then you get a lot of speckling. But you do tend to see it in amyloid, certainly in a later disease. So again, these are just clues that this patient may have cardiac amyloidosis. And then you could do slightly more detailed studies that I'm not an echo expert, so I'm not going to pretend I know all about this, but one thing I always ask my echo techs about is, do they have apical sparing? And the reason I ask for that is, in amyloid, it tends to not affect the apex, and you get this bullseye picture on the GLS pattern where you get the base, the middle of the LV are reduced in their longitudinal contraction, but the apex is preserved. And that's quite a typical feature in amyloid patients. You do get this reduced global strain as well, which is elevated, is highlighted there. And then MRI is something we use a lot in these patients. So obviously echo gives you the index, but we often then go on and request an MRI. An MRI gives similar morphological features of left ventricular hypertrophy and the same with the right. You may get some asymmetrical septal hypertrophy in ATTR in about 80% of patients, whereas light chain amyloidosis from blood dyscrasia often leads to a more concentric pattern. And then the other picture on this slide shows that you get evidence of diffuse extracellular expansion, and that's because the amyloid is infiltrating between the myocytes and expanding the extracellular space. And that's represented by elevated T1. T1 can track with prognosis, so the higher values of T1, the worse patients can do. Again, extracellular volume is elevated, and again, extracellular volume tracks with prognosis potentially. And in slightly more developed amyloid of the heart, you can get focal fibrosis. You can get diffuse subendocardial scar in about 80% of patients, and this crosses coronary territories and often spares the apex, again, fitting in with the bullseye picture we see on the global strain. And if you do happen to get more scar, so transmural scar, again, that seems to associate with poorer outcome, unfortunately. So again, MRI, there are typical features here of the MRI scan that might suggest amyloid. And then the other thing we notice is biomarkers. So BNP and NT-proBNP can be significantly elevated in the 15,000s with a picture of the heart, not so bad. The heart is pumping well, it might be look a bit restrictive, but it's out of proportion. So BNP is often much higher. It tends to be a bit higher in light chain amyloid, again, because of the toxic effects of the light chains, whereas TTR tends to be more indolent and more slowly progressive and less toxic to the myocyte. And the same is with troponin. Troponin is often elevated in these individuals. Again, it's higher in light chain and often can be unexplained. And I tend to use these as markers also because BNP particularly is a predictive outcome for amyloid. So I'm going to, for the sake of time, that's just going over really what I've said. I'm going to move on to my next bit. So diagnosis of ATTR. So this is using the Gilmore model, which is what we use in Leeds, and it's very effective. So you already have a suspicion of cardiac amyloidosis due to hopefully some of the red flags features that we've highlighted there. And in all patients, we will do two tests. We will do a serum-free light chain, serum electrophoresis, and urine electrophoresis, including Ben Jones protein, and then we also organize a technetium DPD scan. And this is essentially a bone scan, but when with TTR amyloid, it mops up the technetium and highlights as a silhouetted heart, as you see here. And it's grade 2 and 3 that are diagnostic of ATTR and not grade 0 or 1. But I'm going to just talk now about the algorithm. So you've got your suspicion, we've done the scan, you've got a grade 0, so it doesn't look like there's any TTR in the heart. Have you got any monoclonal protein as from the blood tests and the urine tests? So if no, then it's very unlikely that cardiac amyloidosis is there, it exists. However, if you've got a monoclonal protein but grade 0 DPD, then you need to, the recommendation is go back and discuss and review the MRI scan to see whether the MRI is also suggested that it may not be involving the heart, but clearly the monoclonal protein will need to be looked at by colleagues in the MDT, such as Chris, who will be talking very shortly. And then you've got the grade 1 DPD scans, which is here or there when it comes to TTR. If you have a monoclonal protein, then that again needs discussion with the hematologist, and we have sometimes debates about this. And you may need to go on to do further tests like biopsy or get a tissue biopsy to try and prove what type of amyloid there is. Now, if you've got a grade 2 or 3 Perigini or Perigini grade 2 or 3 as it's termed, and you've got no monoclonal protein in your test, then you've got a strong diagnosis here of cardiac ATTR amyloidosis. And very often that is what we end up getting with the patients we've put through this process. Unfortunately, this has not come out well, but once you have that diagnosis, you need to genotype. We need to know whether this is hereditary or wild type. Now, as I said, most of this is wild type, but in certain surprises, you do find this is hereditary. In certain younger individuals, this is the case. Those in their 60s, maybe 70s, there's a chance this could be hereditary. And so this is just a quick summary of that algorithm, which I'll just zoom over now. So what about hereditary ATTR amyloidosis? So there's about 100 plus mutations described. It's a relatively small gene, so we can rely fairly well on the test. If they don't have a mutation, then it's very unlikely they will be hereditary. But you'll see here that there are mixed phenotypes, or phenotypes specific to the mutation. So there are some that are very common and lead to a neuropathic presentation. There are others over on the left side there that lead to a cardiomyopathy pattern. But then there are some between that cause a more mixed pattern. But some of these mutations are more frequent. So the most frequent is the V30M. Again, this is the one that I highlighted earlier, that are more prevalent in the Portuguese and Swedish population, but again have a more neuropathic presentation. Then there's two cardiac ones that are fairly common. So the commonest is the V122I, which I've mentioned in an African-American or West African population. And the issue there is it's prevalent in a large population, but the phenotype is maybe not as prevalent. And then you've got the T60A mutation, which tends to be more prevalent in an Irish heritage. and tends to be more common in the northwest, and Northern Ireland, I believe. And occasionally we see a few of these patients in Leeds. So if this is inherited, what do we do about family screening, predictive testing? Do we go there? Well, at the moment, there's no national agreement on this. There's no consensus, and I feel like at the moment in Leeds, we deal it on an individual basis. But they often come to me after they've seen a geneticist, have had their predictive test, and carry a mutation. And the problem there is there's no strict guidance on how to screen them. The genotype-phenotype correlation is difficult. It's not always consistent, and there's a very variable degree of penetrance and expression of that gene. There's also a lot of time between knowing often you've got the gene to progression to disease that might not come on, and that, I think, leads to sometimes quite a lot of fear, anxiety, problems with adapting with the fact, especially if you've seen a loved one die of amyloid, that is a difficult thing to cope with. If you've seen them dying of right heart failure, it's not a pleasant way to unfortunately die. And so people may struggle to understand and cope with the fact they've got a mutation that might or might not give them a condition. So it's a balance, and I think people need to have good, strong counselling before they go through predictive testing. So how do we screen these patients clinically? So they may carry the mutation. Obviously, if they don't carry the mutation, that's obviously the drive to try and have a genetic test, because it excludes them from further screening and relieves them from the risk of the condition. But this paper suggests that maybe we look to screen patients about 10 years before the proband started their disease. So if the proband sort of came about 55, 60 with their condition, you'd be looking to screen their relatives around 40, maybe 45. And then maybe as you get nearer that age, you maybe increase that frequency of screening just to make sure that we're not missing anything around that time. But as I say, the penetrance and expression of these genes is very variable. And then that begs the question, what do we screen with, or how do we screen? And I think that depends a little bit on the phenotype. Now, I'm not going to profess I know how to screen someone from a peripheral neuropathy perspective, and I would leave that to my neurologist or probably the National Amyloid Centre for that. But from a cardiac point of view, an ECG, an echocardiogram, and some biomarkers, NT-proBNP, troponin, are probably reasonable. There's some debate whether all patients should have a DPD scan. I don't think all patients should have a cardiac MRI scan, but the argument for a DPD scan is potentially it's quite a good test to pick up any evidence of TTR, and a negative test would be somewhat reassuring. We don't tend to do that at the moment at Leeds, but I know there's lots of discussions, certainly with the National Amyloid Centre, that may change that approach. So that's my very quick, brief run. Hopefully I've kept just in time, or just, he's let me slip. Excellent, thank you. But any questions? Are we taking them now, or are we going to take them after?
We'll take questions at the end.
Fine, lovely. Thank you very much.
Right then, thank you very much for really practical, sorry, do I need the microphone? Sorry. Right, thank you very much for a very practical rundown of ATTR and some really useful steps on how to sort of take things forward. So next, I'd like to introduce, if you're ready, Dr. Chris Parrish, who's a consultant hematologist at Leeds Teaching Hospitals and St James Institute for Oncology. He has a subspecialist interest in myeloma and stem cell transplant, but also research interest in immune dysfunction, immunotherapy. He's going to talk to us about AL, amyloid, red flags, diagnostic pathway. Right, great. Thanks very much.
Thank you for the kind introduction. So I think I'm in the habit of saying it's lovely to be here in person, but I really mean it today, because not only because this is a lovely place to have a meeting, but also because about an hour ago I was expecting to do this from a lay-by on the A1 where I was stuck in a massive traffic jam. So it is really nice to be here to talk to you. So I'm a hematologist, and my area of interest really is in myeloma and plasma cell dyscrasias. So my kind of input into the amyloid MDT comes from, obviously, from the hematology perspective. And what I thought would be helpful today is to do a bit of an overview of AL amyloid, how it relates to myeloma and some of the other things that we see, and when we need to be thinking about amyloidosis in terms of hematology input and what we can contribute to the MDT. So these are my disclosures. So this is one of those subjects that hematologists dread, is amyloidosis, because I think it's complicated, and actually hematologists think it's really complicated as well. And it's something that we kind of, I think, dread being past the new amyloid patient in the clinic, because it can be quite difficult to work out what to do. So what I'm going to try to cover is what causes it, how does it relate to these other conditions that we talk about a lot, and then a bit about the clinical features and red flags, which obviously kind of tessellates with what Alex has already been talking about. So basically, in amyloidosis, in all sorts of amyloidosis, we're talking about deposition of a beta-pleated sheet, so a protein which is structurally abnormal and composed of some other protein, but then which aggregates into these beta-pleated sheets and deposits in the tissue and causes damage because of its structure and its the way that it impedes the normal function of a tissue. And so there are lots of different types of amyloid, and we'll talk about some of the commoner ones today, but there are lots of rarer ones as well. And in all of them, there's a different protein. And so the question sometimes, once we've identified amyloid, is to work out what the protein is. And in the case of all amyloidoses, there's a sort of a common protein, but then the mystery protein which forms part of the beta-pleated sheet, and we need to try to identify what that is. And often what we see when we've done a biopsy is we see a tissue, and you can do this Congo red stain and see under the right sort of microscopy, you can see this negatively under the right sort of birefringent light, you see a sort of negatively birefringent pattern. And that tells you that there's amyloid, but it doesn't tell you what the amyloid is or what's caused it, what the protein is that's at fault. And in AL amyloid, what we're talking about is that protein at fault being a monoclonal immunoglobulin, or more specifically a light chain, or more specifically still part of a light chain usually, so a degraded monoclonal protein. But there are, as I say, lots of other types of amyloidosis, some of which are very common, some of which have been common in the past, for example, beta-2 microglobulin amyloidosis, which was quite a common feature of dialysis, but which really no longer occurs because of changes and developments in the way that dialysis machines work now, that actually the membranes are able to remove this protein. So the etiology of some of these has changed, and some of these are very rare abnormalities with just sort of small numbers of patients or single families described, but some of them are quite common, and AL is probably quite common. So in AL amyloidosis, the protein in question here, as I say, is part of a monoclonal antibody. So how does that relate to myeloma and the other things that I look after? Well, this is a bone marrow from a patient with myeloma. And what you can see here, that in the place of the kind of normal, very wide distribution of different types of cells as we see in the marrow, I think even without any perhaps histopathological knowledge, you can see that there are quite a lot of cells like this one here, which is a big blue cell with a nucleus and then a big white pale patch next to it. And this is a plasma cell. And that white pale patch is actually the Golgi zone, which, if you cast your mind back to cellular biology, is the bit of the protein, of the machinery of the cell which produces proteins. And you can't normally see the Golgi because it's small and fairly insubstantial, but in plasma cells it's expanded and you get this huge Golgi zone because these cells are just protein factories, and their whole job is to churn out antibodies. And they're the sort of terminally differentiated arm of the B cell pathway of the immune system. And they're antibody factories. And so they produce huge amounts of these antibodies, and I'll come back to that. This is probably the first reported case of multiple myeloma, which is the kind of benchmark plasma cell disease, really. And this is a slide which is obviously very old now, 1844. This was beautiful sort of hand-drawn depictions of the horrible bony abnormalities in this patient. And I think the reason that this is shown so widely is because it was the first report of myeloma, but also because it gives a really graphic description of how horrible a disease this is. And myeloma is still a horrible disease. And we still see people, hopefully not with this kind of horrendous bony deformity, but with severe bony damage as a consequence of their myeloma, particularly collapsed vertebral bodies and back pain. So I've talked a little bit about what plasma cells are already, that everyone's interested in antibodies now because of COVID. But so basically what happens is you have this kind of germline, lots of different options for composing an antibody molecule. And when plasma cells are developing, they pick one from each of these. It's called VDJ recombination, and they produce a unique antibody. So you can produce millions of different types of antibodies. And so these cells are quite active. They divide a lot. They undergo a lot of genetic changes as a normal part of their maturation. And so they often incorporate genetic abnormalities and can become cancerous. And so that's why it's one of the commoner blood and bone marrow cancers, I think. But in any case, what you get is you get production of lots of cells like this that are churning out antibody. And so what we do is called a serum electrophoresis. This is a test we do very commonly. And the basic idea of doing an electrophoresis is that you put the serum into a gel, which is just a sort of matrix, and then you put an electric current across the gel. And so proteins will then move through the gel depending on how heavily charged they are. So the more charged they are, the faster they'll move in the current, and how big they are. So the bigger they are, the more they're impeded by the matrix and move more slowly. So it separates out proteins on size and charge, and this sort of spread out across the gel like this. And these are, when people are reporting plasma proteins, these are alpha, beta, and gamma globulins. So that's what we mean by gamma globulins. It's nothing very fancy. It means this band here. And you can see that in a normal person, what you see is a bit of a range here in the gamma globulins. They spread across the gel because what I've been talking about, they're all randomly created. They're all a little bit different. They all have slightly different size, slightly different charge. They move differently. And so you see this normal spectrum of antibodies. In a patient with myeloma or the other plasma cell dyscrasias, instead what we see is a really tight band because you've lost all of the normal antibodies. They're not making the normal protective antibodies and just churning out loads and loads of this particular protein. And then you can fix them with secondary antibodies to see what it is. It's an IgG kappa in this case, which is the commonest type. So that's one of the tests that we do, and if you see this suggests that if you've got a tight peak like this, which will usually be reported as an M protein or a paraprotein, it means that you've got a clonal plasma cell disorder. There's some sort of cancerous abnormality, and it may be myeloma, it may be one of these other conditions, but in the context of amyloidosis, that means there's a clonal protein if somebody says that, and that raises the possibility of AL amyloid. The other test that we do a lot, which I think is maybe just worth explaining because I think it's a bit confusing, is this serum free light chain assay. So when these plasma cells are randomly combining, they have to choose a light chain. And there are two options. You can have a kappa light chain or you can have a lambda light chain. And plasma cells will randomly choose one or the other. And because you have millions of plasma cells, they will randomly choose one or the other roughly at 1-to-1 ratio. And the normal ratio of plasma cells in your blood producing kappa and lambda is 1-to-1. So in healthy individuals, you see this. In patients with myeloma, MGUS, AL amyloidosis, any other plasma cell dyscrasias, you see a skewed light chain ratio because the malignant clone, whatever it is, has chosen either kappa or lambda, and it makes only that. So if you've got kappa, you'll have a high serum free light chain ratio. If you've got lambda, you'll have a low ratio. And about 9 out of 10 patients with AL amyloid actually have a lambda protein, but it could be either. And so how do we know what this is? Well, the protein, it really just tells you you've got a clonal plasma cell disorder, and then a hematologist is going to be interested and try to work out what this is. And there's a spectrum then of things from sort of solitary lesions, which are a bit more like solid tumours, which we call plasmacytomas, which can be in the bone or the soft tissue, through to MGUS, which means that you have some of these cells in the bone marrow, but they're generally not causing any problem. And that's a very common condition, particularly in elderly populations, and it only has a risk of progression of about 1% per year. So these are people that we monitor, but sometimes they can develop AL amyloid. Asymptomatic myeloma, which really just means you've got more plasma cells, and then through to kind of aggressive end-stage things called plasma cell leukemias. And you can get amyloidosis at any point in this point. So actually, which one of these it is, from the point of view of thinking about the amyloid, is not very important. It's just that you've got a plasma cell dyscrasia that's producing a monoclonal protein. It could be any of these. MGUS patients, just to show you briefly, so we see a lot of these patients and we monitor them, certainly in Leeds now, we monitor these patients through a community monitoring program because there are so many people, we can't keep track of them all in the clinic. And they have a risk of progression of about 1% per year if you follow them over a very long period of time. And because this is often a disease of the elderly, most people will die from something else rather than from their MGUS or from progression of it. So if you've got AL amyloid, what problems does it cause? Well, the problem is this is the kind of MRCP favourite, isn't it? It's one of those things that's an answer to every question, like sarcoid and lupus. It affects almost every body system, but the commonly affected things will be the kidneys, and often presenting with nephrotic syndrome, proteinuria, sometimes with fulminant renal failure. Obviously the heart, again, affected in a high proportion of patients with AL amyloid. Lots of them will have clotting defects. I sometimes wonder whether this is really as high as it is, or whether it's just because hematologists are often involved and they check it. But the traditional classic abnormality is supposed to be factor 10 deficiency, but you can get all sorts of clotting abnormalities. Peripheral neuropathy is quite common, and carpal tunnel is common, and so these things start to create confusion in terms of the phenotype overlapping with ATTR. Liver and spleen is often involved. GI tract is actually very commonly involved, particularly people getting gastroparesis, early satiety, and diarrhea. But actually all of the kind of anything you can think of really can be involved. The only thing that you don't get with AL amyloid is brain involvement because it doesn't cross the blood-brain barrier. So important things to say, it's a histological diagnosis. You cannot make this diagnosis from clinical features and from a paraprotein, because one of the reasons for that is that these light chains abnormalities and MGUS is so common that actually lots of people have it as an incidental finding, and simply identifying that doesn't mean that's the cause of the amyloid. So really what you need is a biopsy, and you need to biopsy an affected organ. We try to biopsy organs that are easy to do and not likely to cause problems. So actually what we quite often like to do is a fat biopsy, an abdominal fat biopsy, which really just means putting in a large bore needle and aspirating some adipose tissue, which you can then stain with Congo red, and that can be quite sensitive. Bone marrow test actually is pretty useless for picking up Congo red. So it'll tell you that they've got a plasma cell dyscrasia that's producing their light chain, which you already know because we found it in the blood, but it's unlikely to detect amyloid. So actually, ironically, it's one of these situations where a bone marrow biopsy is not particularly helpful. And then immunohistochemistry is important, and that can sometimes help you work out what sort of amyloid it is. And we usually send these specimens to the NAC because they will run a large panel of different antibodies to give us a lot more information. And they'll also do electron microscopy and other tests to try to work out what the type of protein is, and that can be helpful. So I mentioned subcutaneous fat biopsies. The other thing which is often a useful site to do is rectal biopsies, so they need to be subendothelial biopsies. And then, as I say, other tests that the NAC can do, they sometimes can sequence the fibrils, mass spectrometry, various immunohistochemistry tests. One thing I would say is that we try not to do lots and lots of biopsies. If you're not getting a diagnosis, multiple biopsies are often not helpful. But SAP scintigraphy, which is a nuclear medicine test, which is offered only at the National Amyloidosis Centre in the UK, can be a really helpful way of picking up AL amyloid in most tissues. Not particularly useful for heart involvement, but most useful for most other features. So I think this should have a heading on, saying when to think about this in the myeloma clinic, because we may or may not have some haematologists with us this evening. But I think things we should particularly think if people have got plasma cell dyscrasias of any sort, MGUS, myeloma, if people develop nephrotic syndrome with substantial albuminuria, this is definitely a red flag for thinking about AL amyloid, and obviously features of that. Hepatomegaly, again, that's not something we do see that with some hematological malignancies, but we don't see it with myeloma. So I think hepatomegaly is something to make you think about this. We've already talked, you've heard from somebody far more expert than me about the cardiomyopathy findings. And peripheral, and actually particularly autonomic neuropathy. So often we find these patients have quite horrible autonomic neuropathy, which can be quite debilitating, including orthostatic hypotension, but lots of, as I say, gastroparesis and other features like that. And one thing I would say is once we pick up one of these things, then the index of, you're really sort of suspicious then about this, and we start to look for other features. I'm not going to talk loads about the prognosis and amyloidosis, NAL amyloidosis, because I think that's probably predominantly of interest to haematologists. But one thing I think that is really worth pointing out is the overwhelmingly most important part in terms of determining prognosis is cardiac involvement. And so the scores that are used now are based upon NT-proBNP, TNT, and the difference between the involved and uninvolved serum free light chain ratio. And you can see that these scoring systems really clearly delineate which patients are going to do well with amyloidosis and which patients do really, really badly. The therapy is essentially based on the sorts of treatments that we use for myeloma. There's been a little bit of a commissioning black spot because it's a rare disease, and we're trying at the moment to get some agreement from NHS England that essentially if a treatment is approved for myeloma therapy, then it's reasonable to use it for amyloidosis, because essentially this is end organ damage because of a plasma cell dyscrasia. And so I think there's some logic for considering it in a similar sort of way. There aren't well-established standards, and we try to enter into clinical trials. And I think one of the good reasons actually to think about setting up local MDTs is to start to think about actually having the ability to run trials locally, because this is a rare disease. The National Amyloidosis Centre cannot see everybody in the UK, and patients certainly from Leeds can't, and certainly from here can't all of them travel to London for trials and for assessments all the time. So I think we're starting to think about a bit more of a kind of hub and spoke model. Our amyloid patients do struggle more with the treatment than the myeloma patients do, so we have to be quite careful about reducing doses and making sure that we're being sensible and pragmatic about what can be delivered. And there's lots and lots of supportive care. I think that's really important with these patients. So we do treat the coagulopathy. They have high thrombotic risk, especially if they've got nephrotic syndrome, obviously, but anybody with amyloidosis, active cancer really has a high thrombotic risk. They often have malabsorption because of GI involvement and need nutritional supplements. And obviously, one of the reasons for talking today is that these patients need a lot of multidisciplinary input, and we now regularly get help from all our colleagues in other teams to manage these patients, which is really helpful. I think makes a big difference to their outcomes. And then the other thing that I think is difficult for amyloidosis, AL amyloid patients, if you think back to the problem in this disease, we're used to in hematology treating the blood dyscrasia and watching the blood cells disappearing and declaring a remission and a success. Or in myeloma even watching the light chains disappear and say the patient's going into remission, and that's great. But with AL amyloid, of course, the real problem is caused by the tissue deposition of the protein in the tissue. So actually clearing the AL, or clearing the light chains from the blood, is only the beginning of the battle, because it's then a considerable delay before the patient will remove any light chains if they're able to do so. So often treatment really is about trying to halt progression by stopping the production of more and more light chains. But to do that, we need to aim for a kind of deep clonal response. So you need to try and clear the light chains as much as possible. I think I've spoken enough about AL amyloid. So we're taking questions at the end?
We'll take questions then.
Right you are.
Thank you very much. Thank you. That's a good question. Right, thank you very much for an excellent rundown on AL amyloid. Certainly something we get spooked about when we see amyloid in the cardiology clinic. So I'd like to just move on to the next talk, and then we can hopefully have a good question and answer session about a lot of the things that have come up in the talk. So our next speaker, Dr. Anshu Sengupta, is a consultant cardiologist, also at Leeds Teaching Hospitals. He has a special interest in inherited cardiomyopathy and its diagnosis by advanced cardiovascular imaging, multimodality imaging, and is also a central member of the Leeds Inherited Cardiac Conditions Group. He's going to talk to us about setting up an amyloid MDT. Thank you very much. Come on through.
Thanks very much. Thanks everyone for inviting us and me to come and speak. So my name's Anshu Sengupta. I'm a consultant, as Ali Khan said, in the Leeds service. So my interests are in heart failure, cardiac MRI, and inherited cardiac conditions, which lends itself quite well to cardiomyopathy. And it's on that basis that I have some ability to speak about an amyloidosis MDT, but actually a lot of the work has been done by really quite a large team of people, of whom you've met a few today. I have a disclosure there about speaker fees just to tell you about. So I got asked to speak to you a little bit about setting up an MDT in Leeds and what our experience has been. So a little bit about the logistics of that MDT, how we've set it up and what we've had to do in the process. A few sort of top tips is what I was asked to tell you about as well. So I'll tell you from our experience what we've struggled with and what we've done well, we think. How much of our things we do locally and how much we will defer up to the National Amyloid Centre and where we get some more specialist input, and some of our future directions and some of our aims for the service as well. And I thought rather than making that into a big narrative, it might be easier to illustrate the utility of something like this with a case for you. So I've got a case to sort of briefly go through, and it will bring through some of the points that Chris and Alex have talked about already. So you've seen the Gilmore algorithm, and Alex went through that on his slides, and it gives us a bit of a feel for what to do when a patient comes to usually a cardiology clinic in this particular instance. The top line is all cardiac presenting symptoms. And I won't go through all of that again. I've deliberately kept the full busy slide because I want to show you all the different people that you need using this. So some of this is about a presenting symptom that is cardiac, so heart failure, syncope, bradyarrhythmia, all the sort of things that Alex was talking about. So you probably need a cardiologist. I'm a bit biased, but I think it's fair. You need somebody who will diagnose ATTR amyloid for you, and for that you need some DPD scanning input somewhere, whether that's in your city or whether that's somewhere in the region. So you need a radiologist with an interest in nuclear medicine. We just heard all this stuff about monoclonal proteins. I have learned a lot in the last 15 minutes that I didn't know despite being part of an amyloid MDT. So we definitely need someone to decode all of this for us, and we absolutely need hematology to be part of that kind of team input. Chris talked a little bit about histological confirmation and all the different stains that you can use. So I think having some histopath input in the region is also useful. And people that are used to seeing these in different subtypes of amyloidosis. You can do a lot through the National Centre, but it's nice to be able to do some of this work locally. Alex talked a lot about genetic testing, and it's no sort of accident that the two of us are in the Inherited Cardiac Conditions Service within Leeds, because actually it means that we can decide who, based on the diagnosis and family history, should have genetic testing. We've got some idea how to do the genetic counselling for mainstream sending off the panels that go to the National Centre, so we can figure out who has given really truly informed consent for genotyping, and then we can start the process of coordinating the family evaluation and the predictive testing that goes with that, hand in hand with genetics colleagues. So I'm not at all saying it should just be cardiologists that do this. You need a genetics team along with this. And depending on what you've got, you then have to be able to manage the condition. So if it's an ATTR, which is what the focus of some of this sort of day is, then you need to be able to link in with other centres and make sure that you can definitely demonstrate that diagnosis and then manage appropriately depending on the genotype and whatever else is going on. It also could be something completely different. So you could have a very neurological feel to your symptoms. You may need some gastrointestinal input as well. And a lot of the time it's sort of slightly rarer types, and some of those are renal. So it's important to have a nephrologist involved in an MDT like this as well. So I'm going to start with some acknowledgements to Dr. Sims, Dr. Kate Gatenby, one of our consultant cardiology colleagues, and to Chris Parrish as well, because I became a consultant after the three of these people, and they'd started some of the work. So it's a little sad that I'm doing this talk rather than one of the three of them, but I'll take some of the credit. I think it's important to find some friends and people that you work with well, because actually a lot of us have this combined interest, and we all wanted to learn more about the different aspects of this condition so we could refer the right people and not waste people's time. So I think it's important to make sure you've got the correct specialties and subspecialties, and find people within your trust or your region that you work with well. And I think that's part of the reason we've quite enjoyed setting up this MDT, is because we actually quite like working together and trying to collaborate. It's important to agree what the combined needs of the service and the region are, so mapping out the pathways for each specialty and presentation. So the Gilmore algorithm there has cardiology presentations as the first line, but actually what if the patient comes in through Chris's clinic or through a neurology clinic or through a renal clinic? So we've sort of done a reverse version of it that I'll show you in a sec. Find out when you might need help, who from, and how would you access that help, and you can set up the structure of the MDT and everything that happens between meetings based around that. And also then you have to think about how many patients you're going to get. Of all the patients, how many are going to need that sort of multi-speciality input, and so therefore how many complex cases in your cohort are you going to have. And once you know all of that, which I think does take a bit of time, set up some sort of MDT and you need to think about how to do this in terms of location, COVID has happened since we started doing all of this, so actually location has mattered a lot less because we've been able to do them over our laptops and over our own office computers at times and do these through Zoom calls and Teams calls. You do need to find some time. So cardiology usually starts at 8. We do a lot of our MDTs at 8, so we've had to negotiate a little bit to get people to come at that time or for us to do things later on and after cath lab or MRI lists or whatever else. It has an impact on job planning. And you might want to do some of this as a combined clinic. We haven't really got to that stage yet, and we haven't had a need because we've been able to discuss patients between clinic appointments and do a lot of it remotely. But it may be that at some point we end up doing something like this monthly and put complex cases in for joint review. And those are the sorts of things that may or may not be relevant in your setup. So our amyloid MDT contains people from cardiology, hematology, neurology, renal, pathology, and radiology. We don't bring radiologists into the MDT meetings because they've usually issued a report that's fairly clear, and the cardiologists do the imaging reporting for both echo and for MRI. We do have a lot of physiologists and nurse specialists within these sort of places as well, so I put the broad specialties in, but it's by no means all medics. And I know we've got a lot of physiologists and scientists on the call, so it's an invaluable contribution we get from all of those people. So I mentioned that we don't always start off with a cardiac presentation. So let's say this patient has come in through either a neurology or a renal or a hematological clinic or something like that. What we've sort of said is that in the specialist review, if they're in a clinic with somebody with an amyloid interest, they should get a basic cardiovascular history and examination. And then if there are things that make you think that there could be a cardiac involvement here, instead of the other way around, we say, right, get an ECG, get an NT-proBNP and a troponin, which we've been advised has a fairly good exclusion value in renal patients. In terms of those, we've also seen that there's some prognostic element to doing those biomarkers at baseline, so it's a useful thing to do if you think there is amyloid affecting the heart. And if those things are normal, then the chances of there being cardiac amyloid are fairly limited, but we do have the ability to speak about those patients if there's other reasons for concern. If any of those things is abnormal, then generally the physician looking after the patient is asked to request an echo and then refer to a cardiologist. Between the two of us and one of the other cardiologists in Leeds, we triage all of our heart failure referrals, so we'll see that kind of thing coming in that referral stream, which means we usually get to it pretty quickly, and then we can either look at the echo and say, actually, that looks all right, don't worry about it, keep following them up, or we might look at it and say, yeah, we should see that patient, we should look a bit further. And sometimes, if there are queries around ECG interpretation, that can be done a bit more informally between us, between MDTs, between discussions, on phone and email contact. And I think we're all fairly open to asking each other questions. Certainly I tend to get pretty quick responses when I don't know how to interpret results that have come through to me. And we can do that either as part of advice and guidance, or we can do it as part of a sort of combined heart failure / acquired heart muscle clinic. And if there are equivocal cases or complex cases, then those come through to our cardiac MDT or sometimes our genetics one, depending on the flavour of the question. So to illustrate a little bit about that, I'll just give you an example of a case where a chap used essentially all of these resources in his sort of pathway. So we had a 75-year-old gentleman who was referred initially to the Rapid Access Heart Failure Clinic. And just on looking at the records, one of the things that had been noted a few years before this was decompression for bilateral carpal tunnel syndrome in the past, which, as Alex mentioned, is something you do often find when you start looking through the records. He had an intermediately elevated NT-proBNP, which is why he came to the clinic, and he's a cardiologist. And I won't spend too much time on ECG because I think that probably bores about 2/3 of the audience, and the other third I don't want to profess to lecture on. But some of the things that Alex mentioned there are present. So you've got actually quite large voltage complexes in some of the leads and quite small voltage in the others. And there isn't a P-wave for every QRS, there's a degree of AV block. So again, the sorts of things that you might see in a patient with amyloidosis affecting the heart. So he went on to have an echo, and I won't spend too much time on this, but essentially heart upside down, the left ventricle is the big thing there that looks like a beaker, the right ventricle you can't really see coming off, but this patient's got quite a lot of extra muscle, possibly a speckled pattern, we're just never really quite sure whether that's actually a thing. Thickening of the valve leaflets, possibly some thickening of the atrial septum, and quite large atria. Unfortunately, the moving image didn't survive the transfer from us to to the slides, but it's a very typical kind of feature. This is essentially a type of feature that shows diastolic impairment, so inability of the heart to relax because of all the deposition of amyloid protein within the myocardium. And there are various different measurements we can do of the longitudinal function, so the way that the heart is moving upwards towards the probe as opposed to just squeezing in systole. And that's a very classic series of findings that suggest cardiac amyloidosis. So that patient went through and we checked the three sort of cardinal hematology tests, and the serum electrophoresis was normal, the Benz-Jones protein in the urine was negative, but he did have a lambda light chain. But we'd also done a DPD scan, and he had uptake in the heart, so Alex talked about perigeny grades of uptake, and he had uptake there, which would usually be suggestive of ATTR amyloid. So we've got somebody who's got grade 2 to 3 perigeny uptake, which would suggest to you that he's got ATTR, but then equally, there was a monoclonal band. So the requirement was then to sort of go forward and do histological confirmation. So we ended up sending samples for histopathology, and there was a colonic polyp that was found, and so that stained positive for Congo red. But actually, he had immunohistochemical analysis at the National Amyloid Centre, and that showed antibodies to transthyretin, which would be more in keeping with that amyloid, which the Congo red diagnoses, being an ATTR form than an AL form. And so actually, the final diagnosis was that the DPD scan gave us the ATTR, and we had a plasma cell dyscrasia as a separate incidental extra finding. So it just gives you a bit of an idea how you need, for some of these cases, you need involvement from various different specialties. And if you don't have all of that, then it's very hard to come to the actual final diagnosis. And actually knowing that this is ATTR allowed us to move on, do the gene testing and all that sort of thing. And it ended up being the wild-type form in this particular gentleman. So that was the main stuff I wanted to say in terms of the way that we've set up our NDT and illustrate it with the case. I've been asked to sort of talk about future directions, and there's so many different things that we could do with this, but we would like to start getting a bit of resource together for a database, thinking about research in the area, quality improvement. We don't have dedicated nurse specialists, but if the service grows and we have enough patients, then it may be that either we end up with a nurse specialist in this region, or perhaps something like a partial role for a heart failure nurse to do these kinds of things. There's going to be discussions ongoing about managing the workload and job planning, and at the minute we're able to put cases into our standard heart failure MDT at regular intervals and then just chat to each other in between times if there's an urgent decision to be made. At the moment, I think that that's sort of working out fairly well for most of us, but it may come that we need to start planning clinics and then having these into our job plans. We need to think a little bit about access to treatments, so there are certain treatments that are only available through the National Centre, and in time it would be nice if there are other treatments commissioned or recommissioned for use in our centre. We would like to be able to have access to those, and we had started that process with one particular therapy. And some of that might involve setting up some formal virtual MDTs with the National Amyloid Centre, but we haven't really had the requirement to do too many of those at this time. But we might be able to save patients a bit of mobility and getting down to the centre. So there's a lot of stuff we could do with this and that we would like to start focusing on. So those are the main things I wanted to say. I think a lot of the questions have been probably sort of talked to by Alex and Chris in terms of the content of our sort of MDT. But if there's any questions about how to set it all up and the utility of it, then very happy to answer those at the end of the talk. Thank you very much.
And thank you very much for a really excellent talk. Just to give us some insight about how these sorts of things work when they're already set up. There's a lot of interest at Sunderland and South Tyneside about being interested in different aspects of amyloid, but whether that translates into an MDT, a working group, or something that actually has some benefit to the patient. I'd be grateful if any of the online participants wanted to put some questions in the chat, because our three guest speakers are scanning it as we speak and ready to answer questions. But whilst they're doing that, I didn't know if there were any questions here at Lumley Castle about what you've heard There is a roving microphone, so that's coming around. Aha, Dr. Will Hinchcliffe, renal physician, Sunderland and South Tyneside.
Thanks. We are on. I don't know how many kidney doctors there are in the audience, but yeah, certainly our contribution to the MDT at Sunderland has detected quite a lot of occult proteinuric CKD that may well be amyloid, but often it's diabetic because a lot of these guys, they've got the continuum of disease. DPD scanning is not something that I'm familiar with. What's your lead time into getting this test done in Leeds? Because I can't imagine that the serum protein electrophoresis light chains take about 3 to 5 days to report. Your echo lead time to requesting in Sunderland South Tyneside is getting better. But essentially your lead time into investigations and then resulting is changes the diagnostic continuum. And these are chronic diseases that are presenting in atypical ways. But yeah, so that's one question that I had. And then the second question was, what is it that Alniam actually produce as far as, is there a treatment that's a thing, and is there just for our interest as to what... So
that might be something we can pick up sort of after the meeting,
okay.
The second aspect of your question. But just before we answer the first part of your question, do we need to be on this microphone for the answers, or are these okay? This one. Right, so who's going to take the question about... So I'll just summarise the question, which is a lot of people don't have that much experience with DPD scanning. What is your access to it? What's the turnaround time? How quickly does it get into your MDT? And I'm going to add a different aspect to that because this came up in several conversations. Where's the money for it? So who's going to take this question? Right, okay. Nobody wanted to take it. Dr. Sims.
So I'll start with the last bit. I can't answer the bit about the money because actually we have a very forward-thinking radiologist at Leeds who was already on the game and the only thing he had to do is make sure we had the right tracer in-house because there's a very specific tracer, I understand. But in terms of the turnaround, we find they come back very quickly actually, and I think that's partly because we send it to a specific individual who's extremely efficient and interested, and turnaround I would say about 4 weeks, 6 weeks, maybe quicker sometimes. So we get it back very quickly, and probably quicker than an echo. So it sort of lends that maybe we screen with DPD scanning, in some people, although the radiology, the exposure to radiation might be another thing to consider there. But we find the access is very easy for us. But I appreciate we're lucky, and I know certainly around West Yorkshire, where we're from, that the access isn't the same in all centres.
In defence, South Tyneside is very quick at doing a DPD scan. And I don't know how much it costs, but again, it depends on having an enthusiastic radiologist and your medical physics department, who are very accommodating in South Tyneside. So...
we are one now, Sunderland South Tyneside, but can you elaborate on how it's gotten to that stage with you?
Well, I mean, one was, as they've all said, it's suspecting the diagnosis, and we made a couple of diagnoses based on, particularly when I was doing cardiology. But I mean, and that's why we developed the scan. We started off by discussing things with the Royal Free and getting permission to do it, and then once you've done it, then your staff get experienced and think about it. And it's thinking about it in the first case.
Just for the record, Mike, I thought you were a chest physician.
I am a chest physician, but I've also done a lot of cardiology in my time.
That is amazing.
You can blame Dr. Nasser.
Take one of these. All right. So I don't know if there were any other questions in the room. There is a question in the chat which we can maybe bounce backwards and forwards to. So in the chat, we've got, could you talk a little bit about the management options open to patients with AL and ATTR amyloidosis? Is referral to the NAC the only way this can be accessed? And I guess what we're saying is, from your talks, the answer is no, there are other options. So, yeah, okay, so just Dr. Parrish.
So I can speak a bit to the AL options. So amyloidosis has been largely up until now, the treatments for AL amyloidosis have been based loosely on those that we use for myeloma. And there's a slightly different and certainly much smaller evidence base for treating the condition because it's a much rarer condition. And so most of what we do is based on using the currently established myeloma therapies and then adapting those and attenuating them to be palatable and deliverable to patients with AL amyloid who often have a lot more end organ involvement and need to have more customized therapies. There have been some new therapies in myeloma which look particularly impressive for amyloidosis, and particularly there's a monoclonal antibody called daratumumab, which is a good drug for myeloma and has been adopted as one of our frontline drugs now, but actually it seems to be particularly useful in patients with AL amyloidosis. And there's also a particular genetic abnormality. So a lot of patients with AL amyloidosis have a translocation 1114, a particular chromosomal abnormality, which is likely to be usefully targeted by a drug that we are hoping to have access to, which has been shown to be effective. So we base this broadly on myeloma therapies. The question about is referral to NAC the only way this can be accessed, and that's definitely not the case, actually. And the NAC are not really in a position to deliver therapy, especially as this tends to be quite frequently administered, so it'll often be weekly therapies or sometimes more than that. So they are very helpful indeed in terms of providing advice and recommendations about what sorts of therapies to consider, but generally that's then delivered locally. And often for our patients, the National Amyloidosis Centre like to track the patients quite regularly, and we'll send them out packs to have light chain tests and so on done on a monthly basis, and then we'll follow those and report back on them, and like to follow them regularly for advice. But the idea really is that the treatment needs to be delivered locally.
Shall I? I think I'm going to go back to the other question because I believe Dr. Gupta has managed to get some figures. Is that right?
Yeah. Yeah. It turns out on a brief email search I have a bit of information because I've had a chat question about the DPD scan and tariffs as well. So I think we are doing 60 DPD scans a year according to the radiology department, and the cost of the scan, which includes the tracer, consumables and time on the scanner, is £300 per patient. So that's what we've been quoted by our radiology lead for this, just for those who are wondering about that.
Shall I take the question about TTR? I'm not entirely sure how much we can talk about treatments. Is that, I can talk sort of as an overall.
Well, why don't we keep that for offline? And
Sure.
Yeah, and then, do you mind if I take that? So I just wanted to, so we can skip past that, but I'd just like to go back to the chat. Louise Clayton's said that she's keen to go back to the question about DPD and tariffs. So you have said to us, Anshu, your costs. So Louise has put her video on, so I'm very grateful because it's always good to see who's asking the question. And my colleagues are going to make that big. It's a lovely big screen, Ms. Clayton. So, but I'm very keen to hear your question. You are on mute, so I'm not sure if we can unmute from here or from there.
So it was just to go, yes, so the tariff for the cost is about £300, absolutely. But I think the problem that we have, and I think one of the chat questions alluded to earlier, is it's not actually commissioned as a tariff reimbursement. So what a lot of centres have done is, as you say, you've got a friendly radiography team who have just kind of slipped them in. So I was just wondering if there was anybody in the audience or in the panel who knows of any other commissioning routes for the DPDs, because at the moment they are not commissioned with a tariff for reimbursement.
So what's the future for that? Because clearly these scans are being done, and at some point someone's going to ask a question about where the money's coming from. Certainly happens to me about everything that I propose doing at work, including coming into work.
So yeah, I think this is the problem. Quite a lot of us are doing them, and like I say, at some point somebody will notice. So the panel have already, in their fantastic talks, I have to say, have alluded to this earlier, that there is this sort of appetite for national registry and the national sort of hub and spoke model with NAC. This was proposed back in sort of 2018 and 19, and then of course COVID kind of hit and everything went on the back burner. But at the moment, there's no sort of immediate plans to kind of bring this back to the specialised commissioning table. So it is something that we really do need to sort of keep raising the agenda for, because it's not just the DPDs, it's it's the whole like I said, job plans, attending MDTs, and if it's not appropriately commissioned, I'm not sure how sustainable it's going to be for some other centres.
Yeah, interesting. And I guess no appetite to take that forward in the near future.
Well, I think there is. I think certainly from the EAMS sites as we were. So there are sort of 15 centres, I guess, that are sort of quite clearly working with specifically cardiac amyloid patients. And so I think there are centres definitely, obviously panel members being some of them that are very keen to sort of push this agenda forward with the patient groups as well. So I think we just need to keep raising the profile, and sort of certainly with the cardiac networks, there's a potential there that the regions might need to flag this up as well as the national agenda.
Okay, right, that's helpful. And I think probably nobody in this audience, in this room, and in a lot of places knows what you've just told us. Just going back to the chat, there is a question about a follow-on question from treatments available for ATTR and AL amyloid. And just going back specifically to AL amyloid, do these therapies that you talked about, Dr. Parrish, do they reverse the myocardial involvement in AL, or is it the underlying monoclonal pathology? And then I'd like to just ask a follow-up on that. Are you happy to take that question? Just hang 1 second.
Thanks. Yeah, that's a really good question, actually. And this is, I think, something that is really important for our patients to understand, and which is difficult, because what happens is they come to the haematology clinic and they see people who say, oh, this is fantastic news, your light chains are going down, you've got a normal serum free light chain ratio, disease is going into remission. And that's what we're sort of in the habit of saying from treating our patients with myeloma and other conditions. But actually the reality is exactly what you say, that really the treatments are about correcting the secretion of the monoclonal protein or the light chain, but that doesn't reverse the tissue involvement by amyloidosis. And so we do see patients who, in patients who can maintain a deep and prolonged serological remission, that they can get slow regression of organ involvement. And I think it's difficult to predict who's going to get that and to what extent, but it can happen. But certainly the treatments themselves do nothing for the organ involvement, and that's just a matter of endogenous remodeling, I suppose, and protein reabsorption. There are a number of therapies that are trying to look at specifically addressing this, including some monoclonal antibodies to target the amyloid protein, and looking whether actually you can then stimulate phagocytosis of the protein and resorption in that method. And other sort of mechanisms for doing that, and so far I'm not aware that any of those have shown very positive results in terms of tissue remodeling. But that's kind of early stages, and that's definitely an active area of research. So I think it's true to say, and I think we need as haematologists to be very clear to the patients about what we're saying there. One thing that we do sometimes do, which is, and I don't know how many haematologists are kind of in the audience, but one thing that I think that is different is if when we have younger patients who are fit and we're thinking about doing treatments like stem cell transplant, there sometimes is, I think, some benefit in a bit of a delay between treatment and going on to those more intensive therapies to give a chance for a degree of tissue, physiological improvement in tissue function, which you do sometimes see. So that's something that the National Amyloidosis Centre sometimes recommend, and that's something we sometimes recommend as well. I think it's no bad thing to have a bit of a gap between treatments, which isn't something we normally do for myeloma and other similar conditions. Yeah.
So I just wanted to ask a follow-up question specifically about what you had said earlier with respect to the National Amyloidosis Centre. Clearly can't take all of these cases, but how does your local MDT, which I accept is probably much more regional than local, how does that tie in? Do you have regular formal meetings with them? Is there, is it an ad hoc thing? What's happening at your centre and elsewhere linking into National Amyloidosis Centre? I'm going to give you the mic to pass on to whoever's going to answer that, but I don't know if you want to take the mic.
Yeah, I mean, I can start answering that. I think at the moment we don't have a regular setup where we speak to the Amyloid Centre, on a monthly basis or 2 monthly basis or anything like that. It is a lot more ad hoc. If we were to find a genetic hereditary ATTR, we would generally refer them along for access to certain management options. And like we demonstrated, there are sometimes cases of diagnostic doubt where that might happen, but it would tend to be, in my experience so far anyway, on an individual case-by-case basis. And I'm not sure if you guys have examples of anything other than that. Before I got here, I'm not aware that there were clumps of cases that were being discussed in one go or anything. Yeah, so it is sporadic.
And I think it's fair to say the volume is fairly low in terms of the need to speak to the NAC. They're an extremely responsive service as well. You can quite happily email Julian Gilmore or others, and they get back to you very quickly with sound advice. I think it's probably a little bit different hematology-wise, because light chain's probably a bit more of a burden, I suspect. But I'll let you maybe answer that.
Yeah, I mean, I think that the National Amyloidosis Centre would actually probably be the first to say that they cannot take ownership of every patient in the UK with amyloidosis, and they are very, as the others have said, they're very responsive and very helpful, but they can't look after every patient. And so I think there is a great appetite from their perspective to try to develop more of a hub and spoke model and a national network, really. But obviously, as with some of the other things we've been talking about, that is contingent on funding, and I know that applications are underway to try to develop more of a national network, because I think there are lots of additional things that we could actually do. And obviously my kind of main focus, I suppose, is on the AL amyloid patients, but for other people that treat those patients, they will know that many of our patients with AL amyloid have really quite severe organ involvement and are not very fit. And actually going to London for 2 days and to stay overnight and have a whole day of assessments and then clinics the next day is not something that's feasible for all patients. But that's not to say that those patients couldn't benefit from treatment. But it's very difficult to deliver clinical trials and so on to actually work out how we are best to treat those patients unless we can capture them and treat them in some sort of national network. So I do think it's quite important that moving forwards we try to look at ways of delivering a kind of cohesive national network, and I know that they're very keen to do that, and we're obviously very keen to be involved in it.
So actually, and certainly that's what patients want, isn't it? They want treatment nearby, and understandably, amyloid is it makes sense to have a national centre, but now we're seeing more of it, and we're getting better at diagnosing it, so it needs to probably move to hub and spoke. So I didn't know, I think Professor Gilmore was hoping to join us, so I didn't know if he wanted to comment on that whilst he's is or isn't on the call. He might want to come on. Just following on then, so you mentioned genetic testing. So I guess this is probably more pertinent for the ATTR. Are you genetic testing every ATTR that you're seeing, and how is that working? Are you using genetic counsellors? Are you doing a single gene panel? Are you looking at the NHS gene panel directory for left ventricular hypertrophy. I know I'm asking quite a few questions here, but I think they're all tied in. And what and where are your options for genetic testing? Has that changed?
Genetic testing in ATTR depends a little bit on the phenotype, I think, in front of you. So if we're happy that this is ATTR DPD scan of a certain age, then what we often do is, I mean, both me and Anshu are fairly with mainstreaming genetics through the ICC service, so we're sort of trained to some extent in counselling and getting consent. So we're quite happy to take that on in terms of genetic testing. That at the moment is a simple blood test that we then send to the NAC. And again, that comes back pretty quickly. It's a fairly small gene. We've apparently mapped a lot of the mutation, so that comes back well. I think there are some cases, particularly maybe not the phenotype is maybe not as strong. You might consider other genetic panels like a HCM panel, but my experience of that is it's often by the time we get to genetic testing for ATTR, it's a fairly strong phenotype, and we're not going down that line on the whole. Do you agree with that?
Yeah, I think that'd be my experience of it. I can't think of a time when we've done it the other way around, where we've had an ICC clinic and a patient with LVH, and this has ended up being what's come on the panel. I'm sure that does happen depending on the breadth of your panels that you've got access to, and the new NHS England one does, I think, have the TTR mutation on it. But in this context, when they come through with a clear diagnosis and you're doing it for ATTR reasons, we would tend to do that in our cardiology clinic, and we have a specific pathway for that. The three of us cardiologists who see these patients will just send off the gene test. You asked about whether we always do it or not. I usually tell them why it would be useful to do a gene test. So firstly, if they've got no family members and they are absolutely not keen to go down to London for any reason, then I would quite often just say, well, the benefit of this in you is more curiosity than anything else. But if things change, we could always do it if you develop a tingling in your hand, and that might make the difference between treatment or not treatment. So give them the benefits of doing it, and what the disadvantages might be depending on the family, where the family are, whether they would wish to be tested. So there's a lot of things that come into that calculation, I think. We would sometimes do that through the genetic service as well. So if there's a patient who's having recurrent trips, rather than us bringing them back into Leeds just to take a full blood count tube, we might ask the genetic counsellors, who have been really responsive in our centre as well, to do that kind of thing remotely. And if and when it does come back positive, then as well as any management changes that we would make, the other thing we do is we feed all these results back to our genetic service, and they coordinate the process of organising family evaluation and discussing predictive testing with other family members at that tenure before the first person got their disease symptoms point.
Yeah, okay. So I know we've got a question in the audience, but just on that topic then of genetic testing, I didn't know if Dorota was joining us virtually, just because there's so many names on the board, whether there was any comments about the future of genetic testing, just whilst that may or may not be happening. I know that, so I don't know if they're willing to comment just whilst they're coming online. Video is always helpful, but don't feel obliged. The NHS panel gene testing is a sort of Pandora's box, I would say, and doing a single gene, I'd feel a lot more comfortable doing. I'd be interested to hear your perspective, Dorota.
Yes, hello, can you hear me? Oh, sorry, you can't see me very well. Okay, yes, so regarding genetic testing, so at the moment, as you rightly said, so at the NAC, we are commissioned by the NHS England, and all the genetic testing is funded by the NHS England, and we obviously, for that reason, we receive a lot of requests from outside of our clinic. However, perhaps the numbers are quite as we expect them to be. With regards to the test directory, so at the moment, the test directory is not crystal clear, but obviously it lists our panel and a single gene test. And it's a single gene test that I would recommend if the phenotype is quite compelling. With regards to genetic testing being funded by the NHS outside England at the moment, that's not planned, and I don't know in the future if this actually will happen. I have spoken with people from our genetic lab hub at Great Ormond Street Hospital, and at the moment there is no future plans with regarding of the NHS England extending their funding to outside of England, basically. So at the moment, it's only requests coming from within England are funded, if that answers your question.
Two other aspects. One is what's the turnaround time and any future perspectives you can give us with respect to single gene testing, for instance, in ATTR?
Are you talking about the turnaround time in when we process the samples?
Yeah.
So it's fairly quick. I mean, the general rule is 42 days for the turnaround time of single gene test, but we tend to, as the panel rightly spoken about the quick turnaround time, we tend to do the genetic testing and send out the results within, on average, I would say about 3 to 4 weeks, or even quicker. It also depends if the request for genetic testing is clear, or do we have to go back to the clinician and clarify exactly what they want. And what I would suggest, I know in the test directory, it states that we do perform the panel, and that can be confusing, but
I'm so sorry to mid-flow. Sorry, you got cut off just at panel.
Okay, so I would suggest if you only are looking for the TTR genotyping, then make it clear on the request form, because if it's not clear, and if by whatever reason it states that you're looking for the amyloid and GS panel, then obviously the turnaround time is much longer.
Thank you very much for getting involved and bringing us the expert opinion. So Jan Oliver in the audience has got a question for us.
I was just wondering if when you genetic test in patients, and obviously you counsel the relatives and they come forward and do the test, and if you pick things up earlier, does it stop a lot of the end organ damage? And what's the life, the relatives?
That's a very insightful question. And the very quick answer to that at the moment is we don't know. I think that's going to evolve. Certainly in the last few years, I've seen an increasing number of patients coming to clinic with a carrier status of one of these genes with no clear expression of disease, and it's not entirely clear when you see them again, how you assess them. Now, at the moment, access to specific hereditary ATTR treatment is based on neuropathy. You have to have neuropathy to get the treatment. It's not based on having cardiac amyloidosis. That tends, in some of the mutations, to come earlier, and potentially seeing me or Dr. Sengupta here or my colleagues is with the wrong people. Potentially, and that's, again, probably leads back to developing your MDT and developing that expertise within your MDT to look at that. But we don't know at the moment whether early treatment stops the progression. I think that's probably the holy grail and the thought and hope that will be the case. But the other thing to mention is genetic mutations. The penetrance and expression is so variable and it's so unpredictable that you might be treating someone who will never get the condition. And that's, I think, the hardest aspect, and probably will get to a point when they have mild polyneuropathy as the starting for treatment is because you know then the condition's being expressed.
Thank you very much. I'm conscious that you guys have got a long way to go home and that it is coming up to 8 o'clock, so we should be closing. I do have one final question, though. Can you have a local MDT if you are not doing cardiac biopsy? You know, everything else is accessible. We've talked about biopsies in all of your talks, but cardiac biopsy specifically.
Yes, I think is the simple answer, because there's so many other different ways you can diagnose the condition, and there's so many other ways to access extracardiac sites. We very rarely do cardiac biopsy in Leeds. We don't have recurrent expertise in it now. So just like you or any other centre that doesn't have biopsy, we would ask our mates in other places. And there are multiple transplant centres close to most places where you could have that if that was the only possibility, but the chances of that actually being the case, I think, are pretty limited. There's usually a different way to find the answer to the question.
And the other thing to say is a lot of these people that have a question of diagnosis, they're frail, and sticking a catheter in the right ventricle and ripping out a bit of muscle. You know, we've seen a few bad results of that, and I think you got to ask the question. You know, what if? I suppose the only diagnosis is if it's light chain, you're going to make a difference. In a frail individual who's got ATTR, you're probably not going to need treatment options other than symptomatic care at the moment. That may change, and we may need to look at that pathway, but we try to avoid cardiac biopsy at the moment.
Fantastic. That's certainly where we're at the moment. So I just want to say thank you very much. So I guess the things to summarise are exactly that. Don't miss AL amyloid. And I guess that drives a lot of the conversations that we've been having. Genetic testing is clearly something important in order to look for hereditary forms and cascade screening, but there are obviously uncertainties about how to sort of take that forward. So I just really want to thank everybody for coming here to Lumley Castle for this meeting, and for everybody joining us in their own time at home, joining us virtually. So thank you very much, Dr. Sengupta, Dr. Sims, Dr. Parrish, who's had a difficult journey here, nonetheless. Thanks again to Alniam Pharmaceuticals for funding this meeting, and for Paul Reynolds for setting everything up with Natalie, and taking this from inception to fruition, which has taken a while, and multiple delays. And so thanks everybody, and I hope that this has been useful for everybody here and online. Great, thank you.